So I'm going to talk about inequalities in the pandemic from a variety of perspectives. And this is based on joint work that I've done with a lot of colleagues from across the country and internationally. And the main output from this has been a book called The Unequal Pandemic, which I did with my colleagues Julia Lynch from the University of Pennsylvania and Catherine Smith from the University of Strathclyde. It's not a book push because you can download the book for free at the web address there. I hope if you do so, that you will enjoy reading. I think it's particularly suitable for students in public health. So what I'm going to talk about today is some of the inequalities by different socio-demographic factors that we've seen in the COVID-19 pandemic. We'll have a particular focus on data from England because that's where our research has largely been based. I will then reflect on how these inequalities can mirror what we've seen in previous pandemics, particularly looking at historical data from the 1918 Spanish flu pandemic. I'll then introduce the concept of a syndemic pandemic, whereby we'll think about some of the pathways and some of the issues as to why we see inequalities in COVID-19. And I'm then going to reflect a bit on what can be done as we're emerging from the pandemic in terms of reducing health inequalities, drawing on historical examples of where we've seen success by governments of various political colours in terms of reducing health inequalities at scale. And I'll then briefly conclude and hopefully enjoy some discussion and questions with you all. So just to give an overview of the sort of inequalities that we've seen, I will draw on data from the United Kingdom, but I know that this social patterning is also something that we see in data from various European countries, including from Germany, where colleagues such as Nico Dragano from Dusseldorf have been doing some leading work in this area. So this chart is showing the accumulated COVID-19 death rates over the first wave of the pandemic. So from roughly March to July 2020 in England and Wales. And you can see from the colours that the pink bars, pink lines represent those neighbourhoods that had the highest mortality rates. And they're the neighbourhoods that had the highest levels of deprivation. So the poorest, the most low income neighbourhoods. As we can see over this period, there was a large gap towards the end of the first wave. And just to put that into some kind of perspective in terms of numbers, and we can see, for example, looking across the United Kingdom, that the COVID death rate, for example, in Scotland was more than double that in the most deprived neighbourhoods, so 86 per 100,000 compared to 38 per 100,000. And we see similar patterns in England and also in Wales, where it's 121 deaths per 100,000 in the most low-income neighbourhoods compared to 65 in the most affluent, the richest neighbourhoods. These inequalities aren't just in terms of when we look at a neighbourhood level of deprivation, so low-income neighbourhoods compared to more affluent neighbourhoods. We can also see that because of the spatial patterning of low-income neighbourhoods, that we also find geographical inequalities at a regional level. So, for example, in these maps of England, we can see that the areas that are more red in colour, both for COVID-19 and for all-cause mortality, are particularly centred, for example, around London, the northwest, and to some extent the northeast, which is where I'm based in Newcastle. We did some analysis with colleagues from the University of Manchester to look at the interaction between the deprived neighbourhoods and region. And what we found is in the north of the country, so broadly speaking, the three regions of the north, the northwest, the northeast, and Yorkshire, we found that here the mortality rate from COVID-19 in the poorest neighbourhoods in the north, represented by the red bar, was much higher than in equally deprived areas in the south. So there's some interaction between neighbourhood deprivation and a wider regional impact. And we've analysed this for a paper that's coming out soon in Health and Place, using the concept of deprivation amplification, arguing that being in a deprived neighbourhood within a region that is also deprived can have knock-on effects, perhaps potentially exacerbating the impact of that neighbourhood deprivation. So we think that there's a kind of northern deprivation effect in terms of the rates that we see. And this might particularly be the case for an infectious disease, which could spread quite easily from one neighbourhood to another, particularly if they have common social risk factors, which we'll discuss later in the talk. So there are strong geographical inequalities, particularly when we look in terms of neighbourhood income and also in terms of the wider regional context. But data from our National Office of Statistics also highlights that there were occupational inequalities in COVID-19 deaths, particularly looking here in the first year or so of the pandemic. And here we can see in these charts for both men and women that the mortality rates were significantly higher in the lower occupational groups, so people involved in elementary occupations. So this would be, for example, cleaners or people, porters, more manual employment, and much lower when we look at more professional groups towards the top of the chart. And we can theorise that that's because, for example, of the impact of the national lockdowns in Europe, how that meant protected some groups of workers more than others. Groups such as ourselves as health researchers were able to work from home and be more protected than more elementary occupations where people still had to go to their place of employment. A very significant inequality in health that the pandemic has exposed in the United Kingdom is the very severe inequalities that we have in terms of ethnicity. This data is taken from the Department of Health from their public health wing, and this shows that, again, looking in this early period of the first year or so, are very significant differences in terms of mortality rates by different ethnic groups. So we can see that it's extremely high amongst Asian and Black British people in comparison to white British people. So we're looking at sort of 3 times higher in some of these ethnic minority groups. And this has become particularly stark and coincided with political movements around, for example, the Black Lives Matters campaign. So they're the inequalities, very much a snapshot of the different facets of inequality that we've been seeing in the COVID-19 pandemic. But as the pandemic was rolling out, people were making comparisons in the media, for example, with what had happened before 100 years ago. And so working with some colleagues, I wanted to explore, were there similar inequalities in 1918 to those that we see today? Looking at some of the analysis which historians such as Sven Mameland from Sweden have done, we can see that there's historical data from 1918 for the Spanish flu epidemic, which shows there were similar social patterning of adverse outcomes from the pandemic in countries such as Norway, Sweden, and the United States. So this historical analysis has found, for example, higher incidence and mortality of Spanish flu amongst the working classes in Chicago, unemployed groups, for example, in Stockholm, and people from lower occupational backgrounds in Oslo, which I will come on to in more detail in a moment. Historical data from England also found that there was a big urban-rural divide with mortality much higher 100 years ago in more urban areas. So in a very important piece of work, Mameland and colleagues analysed historical data from Christiania, what is today called Oslo, the capital of Norway, and they compared the mortality rates in the poorest neighbourhoods in the east, Grøl and Wexels, with those in the most affluent area of the city in Frogner. And they found that during the Spanish flu pandemic, mortality was around 50% higher in the poorest neighbourhoods. They also did some analysis looking at the occupational backgrounds of people, and they found that mortality from influenza was more than 20% lower amongst the more affluent groups compared to the working classes. And other measures of social inequality that would be used at the time, such as the size of someone's home, also found this gradient in terms of mortality rates. So drawing on this historical information and the research that we had done around COVID-19, looking at regional inequalities, then I joined up with a historian, Niall Johnson, and a geography colleague, Dr. Paul Norman, to use our English historical data to see what happened from a regional perspective in 1918 in England and Wales. And as you can see in the map here, again, areas that are shaded red, the more red is the higher the mortality rate. You can see very much that the north and the middle of the country had much higher mortality rates than the south or east of the country. So there are some similar patternings that we can see from a social and a spatial perspective between what happened with COVID from an inequalities perspective and what happened 100 years ago. However, the 1918 pandemic had a much higher mortality rate than COVID-19. And in this table, you can see some examples of the areas that had the highest mortality rates. These are largely from the north of the country. And we can see, for example, that the area with the highest had a death rate of almost 1,200 per 100,000. And the lowest areas had around 200. So there was a six-fold difference across the country in mortality rates. And thankfully, the mortality rates from COVID-19 were significantly lower, and the inequality gap was also smaller. Of course, we don't have to look just back 100 years. We can also look at other pandemics that have happened that are similar, other respiratory pandemics that have happened more recently. And the key example here is the 2009 H1N1 swine flu pandemic. In public health in the United Kingdom, we sometimes refer to this as the pandemic that wasn't a pandemic, because the control measures meant that it was sufficiently suppressed. However, even with very low mortality rates, analysis by Harry Rutter and colleagues has found that there were still neighbourhood inequalities. As you can see in this table, they found that the most deprived neighbourhoods, so the poorest neighbourhoods, had a mortality rate that was 3 times higher than the most affluent, the highest income neighbourhoods. They also found that mortality from H1N1 was higher in urban areas compared to rural areas of England. And these socioeconomic inequalities are also reflected in studies from Canada in terms of analysing hospitalisation rates, and also in the United States, where colleagues have analysed associations between contracting H1N1 and matters of people's income. So we can see that there are inequalities across place, region, occupational class and ethnicity in the COVID-19 pandemic today. We can see that there were parallels with what happened 100 years ago and also what happened in the 2009 H1N1 pandemic. In this next section, I want to talk about some work that I've done with various colleagues looking at what might explain these inequalities. Why do we see inequalities in mortality by socioeconomic status and so forth in COVID-19? And to do this, we drew on the concept of the syndemic. The syndemic was coined and conceptualized by the anthropologist and clinician, Dr. Merrill Singer, in the early 2000s. And he was examining HIV, drug use, and violence in urban areas of America. At the time, these were being treated as separate risk factors for adverse health outcomes, with separate healthcare pathways and separate public health campaigns. In his seminal work, he said that instead of thinking of these as separate epidemics, we should think of them as interrelated. And to do that, he came up with the idea of a syndemic, that these risks, these epidemics were interrelated and exacerbated one another. So drawing on this work from Singer, we applied this across to think about inequalities in COVID-19. And here we visualize this in this picture, which draws on the famous Dahlgren and Whitehead rainbow model of the social determinants of health and adds in the idea of the impact of the social determinants of health on COVID-19. So we argue that we can think of the pandemic as a syndemic of existing chronic disease intertwined with people's differential exposure to the social determinants of health. And I'll talk through now some of the pathways whereby the social determinants of health can adversely lead to worse outcomes from COVID-19. I think we can think, particularly in the early waves of the pandemic, before the vaccine, that there are at least 4 pathways through which we end up with unequal pandemics, drawing on the social determinants. The first one is unequal exposure. So we can think of this pathway as about who was more likely to be exposed to infection from COVID-19. And this particularly would help explain occupational inequalities, for example. People still going to work, still using public transport to get to work, would obviously have greater exposure to COVID-19. This was much more likely for those lower occupational groups. The second pathway is unequal transmission. So once there is an infection within a community or a household, then in housing and neighbourhood conditions within more low-income areas could exacerbate the spread. So, for example, living in an overcrowded house would prevent self-isolation, and likewise, more urban, more dense neighbourhoods are much more likely to lead to community spread. Again, these factors, overcrowding, urban density, are strongly associated with low-income households. The third pathway is unequal susceptibility, and this draws on psychosocial models of health and health inequalities, as well as research on respiratory illnesses, including seasonal flu. And here the argument is that once someone is infected, then people who are from more low-income backgrounds, because their immune system have been weakened by long-term adverse exposures to worse environmental and living conditions, it means that through the chronic stress model, their immune system is less able to fight off the infection and therefore more likely to lead to an adverse outcome, such as hospitalization or mortality, than someone who is in a more healthy position. And the fourth one, which slightly relates, is around unequal vulnerability. And this comes into the social patterning of some of the key clinical risk factors for adverse COVID-19 outcomes. So, for example, in the United Kingdom, diabetes rates, obesity rates, cardiovascular disease rates are all higher in lower income groups. We've done some analysis using decomposition methods to work out which of these 4 pathways was contributing the most to the inequalities by neighbourhood in mortality during the first wave. And here you can see, using a variety of factors to measure each of the 4 pathways, we found that unequal transmission and unequal vulnerability were less important than, transmission was the most important factor, followed by susceptibility and vulnerability. Exposure factors had less of an impact in terms of explaining the gap in COVID-19 deaths. Of course, since the vaccine rollout, we can now think of a potential 5th pathway whereby we may still be having and experiencing inequalities in the pandemic. So as with Europe, the rollout of the vaccine in the United Kingdom has been very thorough, delivered by our nationalised health service, and the reach has been very strong. However, there are still inequalities in who has taken up the vaccine. And so we can see, for example, this data is for Salford, which is a poor, low-income area in the northwest. Then you have 68% of people who had taken the 2nd dose of the vaccine and less than 50% for the 3rd dose. This contrasts to Richmondshire, which is also in the north, but is a much more affluent rural area. Here, the third dose is over 70%. And the chart from the Independent Scientific Advisory Group shows that these inequalities are also patterned, for example, in younger populations. So we can think of an inverse equity effect happening in terms of the rollout of a new medical technology, the vaccine, that the uptake is higher in more affluent groups first, and will hopefully then be picked up later in terms of diffusion by lower income groups. So in this final section, I want to reflect on a broader health inequalities literature to think about, we've seen these inequalities in COVID-19. They parallel what's happened before historically. And we can think about some of the pathways, some of the causes of the inequalities. But in this section, I want to think about what can we do about these? What can we do to reduce health inequalities? And I want to link in to some of the statements that various policymakers made during the pandemic about the need to build back better and to improve things for people after the pandemic. Something which we might want to discuss later in the Q&A is about whether we still think these statements are realistic given political changes across governments in Europe, given the cost of living and the crisis in terms of energy caused by Putin's war. However, to reflect more positively on health inequalities, my argument is and has always been that we can reduce them. They are not something that's inevitable. Policymakers, politicians, the public do have the power to reduce inequalities. And I'm just going to talk through three key examples from across the post-war period. The first one is the Great Society endeavour of Lyndon Johnson and the Democrats in the United States in the 1960s. In this period, there was a big expansion in terms of the provision of healthcare, with, for example, Medicare and Medicaid introduced. There was a war on poverty campaign with initiatives from the federal government to address urban and rural poverty, introduction of their key welfare benefit, aid for dependent children, an expansion of that benefit so that Black Americans were also eligible. Crucially, at this point, we also see the Civil Rights Act, which led to the desegregation of schools and equalised voting rights, desegregated hospitals in the southern states of the US. Research by Nancy Krieger and colleagues at the University of Harvard have analysed the impact that the Great Society reforms had on inequalities in health. And they found that after the reforms, there was a big decrease in both racial and income inequalities in premature mortality and also in infant mortality rates. And they've linked this very much with the abolition of the segregation and the racial discrimination laws in the south of the country. The second example is one that will be much more familiar to you, and I'm slightly nervous about talking about it with the German audience, and I would certainly welcome thoughts and comments. This is about what happened to health between the east and west of Germany after reunification. This has caused quite a lot of interest in England, where we have a significant division between health in the north and health in the south. And there are discussions about what we could learn from what Germany did in the 90s in terms of reducing our own regional divides. As many of you will know, the life expectancy between East and West Germany just before reunification was around 4 years amongst men and 4 years amongst women. And as you can see from these two graphs, over the next 20 years, that life expectancy gap between East and West completely disappears for women and is reduced to around 6 months for men. This is a very significant change in what is quite a small epidemiological timeframe. Researchers working on this topic have theorized that the reasons might be the significant upgrading of the healthcare system, which significantly helped, for example, reduce infant mortality rates in the East. The second argument is around the economic side of reunification, particularly the impact that having higher pensions had on older age mortality. And thirdly, the argument is around changes in people's consumption and health behaviours, with more access to fruit and vegetables and a decline in smoking rates. I would imagine that the truth lies between a mixture of those potential mechanisms, and as I said, it's something I'd be very interested to get your thoughts on. Nonetheless, these significant inequalities were reduced during this period. And my final national example comes from the health inequalities strategy that was implemented in England in the 2000s. Here, the government of the day introduced various mechanisms such as increased funding to the health service within more deprived, lower income areas, big introductions in terms of expansion of the welfare system to support children and to reduce child poverty. And for example, at the other end of the life course, increases in the state pension in order to take 2 million pensioners out of poverty. Working with colleagues at the University of Liverpool, I've been involved in a series of quasi-experimental study designs to retrospectively analyse the impact of this strategy on health inequalities. And in the first chart, this examines what happened to inequalities in mortality amenable to healthcare, comparing the most deprived, so the poorest areas, with the average for the country. The poorest areas is the blue line and the average is the red line. And as you can see, over the strategy period from 2000 to 2010, the gap between the bottom and the average closes. Similarly, as the other chart looks at trends in infant mortality rates, again comparing the average with the most deprived local authorities. And again, during this period, we can see a significant closing of the inequalities in infant mortality rates. Beyond 2012, when we started to have austerity and a reduction again in the welfare state in England, then you see a big increase again in the inequalities in infant mortality rates. So the strategy period had a significant impact in reducing health inequalities. So just to conclude, I've tried to cover quite a lot of material around the pandemic and beyond the pandemic in terms of thinking about social inequalities and the social determinants of health. Research from my group and from others has shown that COVID-19 outcomes are much worse in more disadvantaged groups and more marginalised communities. We've argued that COVID could be understood as a syndemic, the interaction of pre-existing health conditions, inequality, and the social determinants of health. We can also see that the inequalities in COVID mirror inequalities in previous pandemics, but we can do better. We can learn from what's happened in the past in terms of levelling health and think about some of the key mechanisms around healthcare, expansion of social security, and the political incorporation of minority groups. Ultimately, we need more long-term public health and prevention action that targets the social determinants and targets those communities most in need in order to reduce inequalities in non-communicable diseases and have a healthier, more resilient population for the pandemics to come. Thank you very much for your attention.
Thank you very much, Professor Bambra, for an excellent presentation. This is open for discussion now, in the front and in the back. We only have one microphone.
I'm sorry, I can't hear the microphone.
I can repeat the question. Was being poor and being vaccinated is an advantage. This was the question?
Being poor is a disadvantage? And being poor means you're less likely to be vaccinated.
Yeah. There's another question over there. And I can repeat the questions. If perhaps the microphone is not on. Is it? Okay.
Should I start? Yeah. As an economist, I have learned the hard way that we have to really distinguish very carefully between association and causation. And in your fascinating talk, you mentioned many associations and put evidence forth for them. And you talked about the pathways which goes in the direction of finding out about the actual root causes. But nevertheless, in your list in the end, I think one thing I would like to add for this literature, which is as long as we don't take much more carefully the communication with our recipients as one of our targets, distinguishing between, do I look for associations because I want to predict, for example, in which neighborhood I should administer my policy, I should send in a vaccination team or something, or do I look for the root causes? It's not very much the same. We need to distinguish the two, and I think that's a real lack in the discussion on public health, especially since our recipients in policy-making scenes and in the general public don't understand that, and we need to, I think, inform them about that.
Thank you. I could hear that question, and thank you very much for your comments. I agree with you. I mean, most of the studies are not predictive and are not trying to draw out causal. So when I was using pathways, I was doing it from a theoretical pathways perspective. So it's my kind of estimation based on the theory as to what might be causing the inequalities. But yes, these would need to be tested. However, I think because of the way the pandemic was, we kind of, as a public health community, didn't have the luxury of going down that route. We needed to be able to predict, for example, where hospital beds would be most needed most quickly as the evolution of the pandemic happened. And so for that, then yes, I know that within our health service, for example, we were using associations, knowledge from practice to try and predict where we might have bed shortages, particularly in the first wave.
Thank you very much for the presentation. My question is whether there are any best practices in public health policies which might be employed to counter the inequalities that we saw.
Thank you. This is always very difficult. I have as a social scientist, quite a societal view on what's needed to reduce health inequalities. And I presented some of that in my examples. But when we want to look at more specific inequalities, then obviously we would need to think about potentially particular interventions that could be rolled out. So some of the work that we've been doing at the moment with our local health care providers is thinking about how do we increase the vaccine uptake in our most deprived neighbourhoods and trying to evaluate the methods that are being used there and learning from methods around, for example, childhood immunisation uptake. But I'm afraid I don't have a simple answer because the health inequalities are this kind of syndemic of interactions and we need to target, in a sense, the whole of that system rather than just one or other aspect of it. I hope I understood your question correctly.
Hi, I'm Bernhard Goodwin. I'm a scholar in science communication, and that's of course why I'm looking at the communication part of the question. I wonder whether the rates of the different vaccine rates in different groups maybe also have something to do with different levels of trust in society. Maybe rightly so, because if you experience society as hostile or authorities as people who treat you well badly or as an object, then you might have less trust in these institutions.
Yes, I think that's an important point. And we did some survey work looking at why there was vaccine hesitancy amongst particular groups. And certainly what you've said about social trust was a key issue, particularly amongst our ethnic minorities. And as you say, similar to the reasons you've suggested, their interactions with state authorities are often quite negative. It's often about surveillance in terms of whether they've done what they should do in order to receive their social security. It's very hard to then say the state's benevolent and we're giving you this vaccine and there's nothing to worry about it. So yes, there's been concerns that that's one of the key issues that we're facing, and that's very difficult for us as public health community to overcome, because again, it's to do with societal power structures that are alienating people even from things that, you know, that are good for their health.
Thank you so much. Are there any further questions from the auditorium? I don't see none. So thank you again, Professor Bambra. Great having had you here, and I hope you can enjoy the rest of your day. I hope the weather is as nice as here in Halle currently, but I don't know, of course.
Thank you, yes. And I hope to visit you at some point.
Bye-bye.
Thank you.